Hello everyone, welcome to AACCM e-learning channel. Myself, Dr. Ankit, is going to discuss the second part of hyponatremia today. That's being the clinical features, the typical scenarios which we see in the ICU nowadays, which will cause hyponatremia. And the third thing, the important part, that's the treatment part, right? So here, for the particular clinical features, I have made this particular mnemonic. It's from various sources. That is, hyponatremia, there is a loss of salt, right? So we have made this mnemonic here, loss of salt. You can easily remember the names as L for lower limb and upper limb weakness, right? O for orthostatic hypotension. S for stomachache. And S for seizures, right? Then salt, that is stupor, anorexia, vomiting, nausea. L for lethargy, and T for reduced tendon reflexes, right? So this is the a simple mnemonic for the clinical features of the same, the hyponatremia. Now let's discuss certain important scenarios in which we can see hyponatremia per se regarding the same, which are given here. They are: number one, hyperglycemia, right? The second is edema. Third is SIADH. We all know, symptom of the inappropriate ADH secretion, right? These three are the things which we're going to discuss today. Hyperglycemia presents as hypertonic. Why hypertonic? Due to increased levels of glucose in the blood. Hyponatremia, right? Hyperglycemia presents as hypertonic hyponatremia. Why? We all know that glucose is an osmotically active solute, right? It is an osmotically active solute. Right. And in states of insulin deficiency, we can tell that in case of insulin deficiency, what happens? There's increased rise of glucose levels in the blood, right? That means in the ECF, the glucose is more when there is insulin deficiency and there is increased rise of glucose in the blood. Isn't it true? Right? So what happens in case of marked hyperglycemia of diabetic ketoacidosis, in case of DKA, right? What happens is there is hyperosmolar hyperglycemic state. Right? What happens? There is increase ECF osmolality. You can say more than 290 milliosmol per kg, right? Then what will happen? There is shift of fluid, right, or water, you can say, from the intercellular compartment to the ECF compartment. Water shift from ICF to ECF, right? It will cause what? As simple as that. It will cause dilutional hyponatremia. All right. This is what exactly happens in case of glucose increment in the body or glucose levels when they get high in the blood, right? And we can say a simple notion here that for every 100 milligram per deciliter rise in plasma glucose, the sodium falls by 2.4 milliequivalent per liters, right? This is a simple scenario in which we can see why hyperglycemia causes hyponatremia, right? Let's come to the second point, edema. What happens exactly in edema? Why edema happens, we all know, in case of cirrhosis, isn't it? CHF, these are the edematous states, isn't it? What happens because of this? There is reduced effective circulating blood volume, right? This is what happens, right? In case of edema, more of the fluid is in the ECF, not in the ICF, isn't it? What happens because of that? There is a non-osmotic ADH release to conserve the extracellular water, isn't it? What happens because of that? Increase in the total body water, isn't it? This will cause again dilutional hyponatremia, right? So this is what happens. Now let's talk about why there is hyponatremia in SIADH, right? So what is SIADH? We all know that is a symptom of inappropriate secretion of antidiuretic hormone, isn't it? So now what happens in this particular state or syndrome? There is impaired water excretion, isn't it? There's impaired water excretion which is caused by, ability to suppress the secretion of ADH. If water intake here, if water intake exceeds the decreased urine output, there is hyponatremia, right? And a simple thing, in this SIADH, the urine is not very concentrated, isn't it? There's no enough water which is excreted, and there is too much water in the blood. This particular scenario dilutes so many substances in the blood like sodium, potassium and whatnot. Ultimately there is low blood sodium level, and that is why there is hyponatremia in case of SIADH. Alright, so now let's move on to the treatment part. Okay, so this treatment of hyponatremia, we all know hyponatremia is severe hyponatremia less than 130 milliequivalent per liter. Okay, you have to check for the severity of this particular scenario. Okay, severity in the sense is acute or chronic. Okay, acute will be symptomatic, as we all had discussed in the the mnemonic salt loss. It will be around less than 2 days. Chronic will be more than 2 days, and this will be asymptomatic. Okay, in case of symptomatic, what you have to do is we have to restrict the water. Okay, to use hypertonic saline, right, at 1 to 2 milliequivalent per liter. This is the correction rate, right, till the symptoms subside. We will use an equation here for calculation of the rate of change of serum by 1 liter of infused fluid. That is the Andromeda's equation, which is infused sodium plus potassium minus serum sodium upon total body water plus 1, right? And how do you calculate the total body water? It's a simple formula. You multiply the body weight by 0.6 in general scenario. Okay, now what happens when the symptoms improve? Once the symptoms improve, you have to correct the sodium levels by not more than 0.5 milliequivalent per liter per hour, okay, or we can say it as 12 milliequivalent liter per day, right? The scenario. Alright, now this is the thing which you have to remember. Why? Because this will cause central pontine myelinosis. Okay, this is about the scenario of symptomatic or acute hyponatremia when it is presenting with less than 2 days. Remember the mnemonic salt loss for the same, right? Let's talk about the chronic or asymptomatic hyponatremia. It doesn't require no immediate correction, right? Obviously water restriction, same thing. Remember here, do not correct at rate of more than 0.5 milliequivalent per liter per hour or 12 milliequivalent per liter per day. This we should remember, right? Now let's see this particular scenario by an example. Okay, an example being, you can say a 75 years old man presents with sodium of, you can say, 110 milliequivalent per liter, with stupor, abdominal cramps, and weakness of lower limb bilaterally, right? Now we conclude that, or the doctor who is treating the person concludes that the sodium needs to be increased by 4 milliequivalent per liter in 2 hours using 3% of hypertonic saline. Okay. Now we have to remember here how to actually change, calculate this particular thing here. First we should calculate the total body water, that is 70 into 0.6. we have seen it is 42 liters, right? We know 3% hypertonic saline contains 513 or 12 milliequivalent per liter. Okay, normal saline contains 154, RL contains 131. Okay, All these things we should remember. Okay, now we can see in case of hypertonic saline, we're using hypertonic saline, right? So we can see the expected change in sodium concentration per liter of 3% hypertonic saline, that is 530 minus what is the given value here, 110, right? We're using the Hydrog-Mediage equation here, divided by 42 plus 1. Yes, now this will come, we can see here the amount of fluid required to achieve the change, achieve the goal, that is 4 upon this particular value. This will come to 9.3. okay, that is 0.4 liters. Okay, so now what is the rate of infusion? That is, this is 0.4 liters, this is 400 ml, right? 400 upon 2, that is 200 ml per hour. This 2 comes from here, right? This is how we correct the sodium in case of hyponatremia. Alright, so thank you so much. This is the discussion we have done in 2 parts. In case of hyponatremia, I have tried to explain it in very basic and short form. Kindly do subscribe the channel AACCM, like and comment if you have not understood anything. I'll try to come live someday and we'll try to sort the questions or the answers out there. Thank you so much.